from Saudi Arabia Ministry of Health. Diabetic ketoacidosis management protocol for adults more than 14 years. So, diabetic ketoacidosis is defined by biochemical triad of ketonemia, hyperglycemia, and acidemia. Ketonemia, hyperglycemia, acidemia. So, DKA biochemical triad, ketonemia, hyperglycemia, and acidemia. The main treatment of DKA is rehydration, insulin, and electrolyte balance, mainly potassium, together with identification and treatment of precipitating factor. So, the main treatment of DKA is rehydration, insulin, electrolyte balance, mainly potassium, and identification and treatment of precipitating factor. Type 1 diabetes mellitus. Type 1 diabetes mellitus subjects are at risk of developing DKA if any acquired infection secondary to frequently missed insulin doses or due to market stress. So, type 1 diabetes mellitus risk factor for DKA is infection, missed insulin doses, or market stress. Furthermore, subjects with newly diagnosed type 1 diabetes often presented with DKA. Also, patients with type 2 diabetes mellitus may present with DKA if they have persistent hyperglycemia for long periods of time or they become under the effects of stress. The diagnosis of DKA is not difficult and depends on the finding of acidemia, ketonemia, or significant ketonuria, and hyperglycemia. The treatment of DKA mandates good monitoring of a fluid state, electrolyte, acidosis, and blood sugar. This is simplified protocol for management of DKA prepared after extensive review of the available evidence-based medicine and clinical practice. Most importantly, this protocol provides general guidance. However, it may not suit all patients and will not replace the clinical judgment of the treating physician. So, clinical presentation. The most commonest clinical presentation of DKA and hyperosmolar hyperglycemic syndrome is due to hyperglycemia and include polyuria, polydipsia, weight loss, weakness, physical signs of dehydration, such as dry buccal mucosa, sunken eye balls, poor skin texture, tachycardia, hypotension, shock in severe cases, that cause malrespiration and accidental breathing, nausea, vomiting, and abdominal pain may be also primarily in DKA. Abdominal pain correlates with the severity of acidosis. So, the diagnostic criteria of DKA, plasma glucose more than or equal 200 milligram per deciliter, that is 11.1 millimole, or non-diabetes, or plasma glucose equal or more than 200 milligram per deciliter, is 12.1 millimole per liter, positive serum ketones, or significant ketonuria, more than or equal 2 plus urine ketone, and venous or arterial HCO3 less than 15 millimole or pH less than 7.3. HCO3 less than 15 millimole per liter and or pH is less than 7.3. All three biochemical criteria are required for diagnosis. So, hyperglycemia, equal or more than 200 milligrams per deciliter or 11.1 millimole, or the patient is non-diabetic, positive serum ketones or significant ketonuria more than 2 plus, urine ketones, venous or arterial HCO3 less than 15 millimole, and or pH is less than 7.3. All three criteria are required for diagnosis of the DKA. And also we know that clinical presentation of hyperglycemia, that is polyuria, polydipsia, and weight loss, weakness, and the clinical presentation of dehydration, like dry buccal, sunken eye, poor skin turgor, tachycardia, hypotension, and of the acidosis, that's causal respiration, acetone breath, nausea, vomiting, abdominal pain. And the three criteria: 200 milligrams per deciliter, and ketones, and HCO3 less than 50. Investigation. The investigation should be directed toward finding the precipitating factor and should be ordered by the treating physician whenever it's appropriate. Markers of severity. This marker of severity managed in HTU or ICU. Glasgow scale less than 12. pH less than 7.1. Serum ketones more than 6 millimole. HCO3 less than 5 millimole. Potassium less than 3.3 or more than 6. The SPB, systolic blood pressure, less than 90. The oxygen saturation less than 92 in room air, and pulse rate is more than 100 or less than 60 beats per minute. The urine output is less than 0.5 ml per kg per hour, or evidence of acute kidney injury. So this is markers of severity to manage the patient in HDU and ICU. The Glasgow scale less than 12. The pH less than 7.1. Serum ketones more than 6. HCO3 less than 5. Potassium less than 3.3 or more than 6. Systolic blood pressure is less than 90. Oxygen saturation in room air is less than 92, and the pulse rate more than 100 or less than 60. Urine output less than 0.5 ml per kg per hour, or evidence of acute kidney injury. Treatment of DKA include fluid therapy, insulin, potassium therapy, bicarbonate. So, the fluid therapy in treatment of DKA. Patients with DKA usually present with variable degree of dehydration, up to 6 liters, and will require gentle and well-monitored fluid replacement. The initial fluid of choice is isotonic saline at the rate of 15 to 20 ml per kg per body. 15 to 20 ml per kg body weight per hour, or 1 to 1.5 liters during the first hour. The choice of the fluid for further repression depends on the hydration status, serum electrolyte levels, and urine output. In patients who are hypernatremic, the 0.45% in ACL infused at 4 to 14 ml per kg per hour is appropriate, and 0.9% in ACL at similar rate is preferred in patients with eunatremia or hyponatremia. The goal is to replace half of estimated water deficit over periods of 12 to 24 hours. In patients with hypotension, aggressive fluid therapy with isotonic saline should continue until blood pressure stabilizes. 2. The protocol is not designed for patients who are hemodynamic unstable and those who require management by ICU team. Quick and over replacement of fluid is associated with morbidity in DKA subjects like cerebral edema. Therefore, physicians should always pay attention to the amount of the fluid given. So, the fluid therapy, patient of DKA is present with dehydration, so requires gentle, well-monitored fluid replacement. Initial fluid to choice is isotonic saline at rate of 15 to 20 ml per kg body weight per hour, 15 to 20 ml per kg body weight per hour, or 1 to 1.5 liters during the first hour. The choice is depends on hydration status, serum electrolyte, and urine output. If the patient is hypernatremic, then the fluid to choice is 0.45% chloride sodium infused at 4 to 14 ml per kg per hour, and we will choose the 0.9% from chloride sodium at similar rate in patient who is eunatremic or hyponatremia. The goal is to replace the half of the estimated deficit at a period of 12 to 24 hours. In patients with hypotension, the aggressive fluid therapy with isotonic should continue until the blood pressure is stabilized. The common complication of fluid therapy in these patients is cerebral edema. Other treatment in DKA is insulin. Treatment with intravenous insulin should be established once the serum potassium level is more than 3.3 milliequivalent per liter and should be continued till the patient is out of DKA and can be shifted to subcutaneous insulin. The only indication to stop insulin is when the potassium level is less than 3.3 milliequivalent, where replacement with potassium chloride should be done before insulin is started. The initial insulin dose should be 0.1 units per kg, which should be lowered to 0.05 units per kg if the blood sugar is less than 6 millimole. As in the order sheets of a protocol, to avoid hypoglycemia, 25 cc of D50% saline can be given as bolus whenever the PS falls below 4 millimole. The other option is to add D50% to the existing fluid to increase and maintain the blood sugar in the target level. So, insulin, intravenous insulin, established when the serum potassium level is more than 3.3. Continue till the patient is out of DKA and can be shifted to subsequent insulin. The only indication to stop insulin is when potassium level is less than 3.3, then the replacement of potassium with the chloride potassium should be done before insulin is started. The initial dose of insulin is 0.1 unit per kg, which should be lowered to 0.05 units per kg if the blood sugar is less than 6 millimole. So, to avoid hypoglycemia, we can use 25 cc of P50% saline as bolus whenever the blood sugar falls below 4 millimoles. The other option is to add D50% to the existing fluids to increase and maintain blood sugar in the target level. The potassium therapy. Most morbidity and mortality in DKA come from mismanagement of potassium replacement. Although total body potassium is depleted, mild to moderate hyperkalemia is frequently seen in patients with DKA due to acidosis. Hyperkalemia in patients with DKA is due to acidosis, proteolysis, and insulin need. Insulin therapy, correction of acidosis, and volume expansion decrease the serum potassium. The insulin therapy and the correction of acidosis and volume expansion, this will decrease the serum potassium concentration. To prevent hypokalemia, potassium replacement is initiated after serum levels fall below the upper limit of normal. Patients with DKA who had severe vomiting or had been on diuretic may be present with significant hypokalemia. In such cases, potassium replacement should be begun with the fluid therapy, and insulin treatment should be postponed until potassium concentration become more than 3.3 in order to prevent arrhythmia and respiratory muscle weakness. Then, the order sheet outlines few points to take over in case of severe hypokalemia. Good monitoring of potassium level is critical during the management of DKA. The order sheet provides flexibility for the physician to select timing of repeating the level. However, aggressive monitoring may be needed, especially for those unusually presented with hypokalemia. So, potassium therapy. Most morbidity and mortality in DKA come from mismanagement of potassium. The complication of potassium in DKA is either hyperkalemia or hypokalemia. The hyperkalemia is due to acidosis and proteolysis and insulinopenia, and the hypokalemia is due to insulin therapy, correction of acidosis, and volume expansion. So, to prevent hypokalemia, potassium replacement is initiated after serum level fall below the upper limit of normal. Patients with DKA who have severe vomiting or on diuretics may present with significant hypokalemia. In such case, potassium replacement should be begun with a fluid therapy, and insulin treatment should be postponed until potassium concentration become more than 3.3 in order to prevent arrhythmia and respiratory muscle weakening. The bicarbonate management. Bicarbonate is not routinely needed only in cases of severe acidosis, so pH is less than 6.9, not responding to initial treatment. Bicarbonate is not routinely needed only in cases of severe acidosis. pH is less than 6.9, not responding to initial treatment. If patient is less than 6.9, then sodium HCO3 as 50 millimole diluted in 200 ml of H2O infused at 200 ml per hour. Hold if potassium is below 3.3. Repeat HCO3 infusion every 2 hours until pH is more than 6.9. Monitor potassium levels every 2 hours while on bicarbonate infusion. So, if pH is less than 6.9, then in HCO3 50 millimole diluted in 200 ml of H2O infused at 200 ml per hour. Hold if potassium is below 3.3. Repeat the infusion every 2 hours until pH is more than 6.9. Monitor the potassium level every 2 hours while in bicarbonate. Criteria for switching to subcutaneous insulin. Criteria for switching to subcutaneous insulin. When venous HCO3 equal or less more than when HCO3 equal or more than 18 millimoles per liter and or pH equal or more than 7.3 and close anion gap. The patient is able to take orally overlaps the first dose of rapid-acting insulin for 1 hour with the insulin infusion before stopping. So, criteria for switching to subcutaneous insulin when the venous HCO3 equal or more than 18 millimole per liter and or pH equal or more than 7.3 and closed anion cap, and the patient is able to take orally overlap the first dose of rapid-acting insulin for 1 hour with the insulin infusion before stopping. Order sheet for the management of adult patients more than 14 years old. Please admit the patient to general ward ICU as a case of secondary to under the care of doctor. Write your name, then the vital signs, just go coma scale, the diet, urinary catheter, NG tube needed, investigation, venous blood gases, urea electrolytes, CBT, urine analysis, urine ketones, urine calcium, then check investigation, phosphorus, monitoring the fluid. If the patient is hemodynamically stable, don't use this protocol. Insulin, don't start insulin till potassium level is available. Potassium chloride replacement, and so on. For subjects who present with unexplained hypoglycemia, we complete another